Hello everybody, this is Dr. Javed. I'm going to be talking to you today about chest imaging. My only disclosure is that most of my images are from Google search. Our learning objectives for today are to describe the basic patterns of chest X-ray and CT, to recognize common abnormal radiographic patterns. We will try and develop a basic interpretive strategy. So let's start with the clinical case. A 46-year-old female comes to the office with complaints of 2 days of shortness of breath and cough. She has had some hemoptysis, but she's not able to quantify it. She is a smoker. Her blood pressure and temperature are normal. Respiratory rate is 30 breaths per minute, and heart rate is 100 beats per minute. So as you think about this case, try to come up with a differential diagnosis and start thinking about how you would work up this patient. I would suggest you pause the slides here and write up a differential diagnosis and some workup before we proceed. Let's talk about image acquisition. Images are interactions of 7 different radiographic densities. Visual discrimination occurs from differential energy absorption by these different densities. This leads to a radiographic interface. Both the absence of normal and the presence of abnormal are important when interpreting X-rays. This is a graphical representation of the 7 primary levels of image density when we're scanning with conventional X-rays. If you look towards the left, the darkest or blackest is air compared to the whitest, which is going to be metal, and there are several gradations in between. As the image density increases, the brightness or whiteness of the picture increases. Another way to think about this is to think about X-ray transmission versus absorption. Higher density substances will absorb more X-rays. They appear brighter, but they also become warmer or hotter as they absorb X-rays. Conversely, lighter materials will transmit more X-rays and hence appear blacker on X-ray pictures. Let's talk about some basic patterns of chest X-ray and CT. But before we do that, let's look at some common terminology. Here, we can see that the X-rays are going to be directed from the patient's back to the front, where the image is going to be acquired. This is called a PA, P standing for posterior and A standing for anterior view of the chest. This is how a typical PA film would appear. I have placed an anatomical landmark cartoon next to it to show that there's significant correlation between what we see on an X-ray and what can be visualized on gross anatomy. The main significant structures are marked on this X-ray for you to review. A lateral view of the chest is just as important as a PA view. Again, major structures are marked for your review on this X-ray. Notice the position of the patient. The X-rays are going to be directed as if we are looking at the patient with the plate behind the patient to get a film. Another common view in chest X-rays is an AP view, A meaning anterior and P meaning posterior, where the rays are directed from the anterior portion of the chest, whereas the radiographic film is on the posterior part of the chest. This is a common view that's used in patients who are unable to be transported, for example in the ICU where I work. These are some PA and lateral views of the chest, denoting most of the common structures or lobes of the lung. RUL stands for right upper lobe, RML stands for right middle lobe, and RLL stands for right lower lobe. If you notice that the right middle lobe and the right lower lobe overlap on a PA film. There are major differences between chest X-rays and CT scans. Chest X-rays are 2D versus 3D for CT scans. The chest X-rays are low resolution versus CAT scans or CT scans are better resolution, almost by a factor of 200. Chest X-rays are less accurate for diagnosis, again because of the low resolution. We can get a much better, more accurate diagnosis with CTs. This accuracy is reflected in the cost, lower cost for chest X-rays and higher cost for CT scans. Similarly, chest X-rays are portable and can be done around the hospital versus CT scans, which are not generally portable. Although there are some newer CT scanners for the head that are available in the ICU. There is also significant difference in radiation dose between chest X-rays and CTs as mentioned. X-rays are quick to do versus CT scans, which are not very quick, although they're not slow either. On X-rays, we have imprecise segmental localization versus CT scans will give us a much better picture of segmental localization, which translates into defining disease processes better. Here is a picture of a patient going into a CT scanner. The big round donut thing that you see behind him is the CT scanner. CT scans were also called helical CTs because as the patient's body is passed through this donut hole, the ring around it rotates and scans through different portions of the body. CT scans give us a much better view and a three-dimensional view of the body or organ that is being imaged. On the top right portion, you can see a transverse view with major vessels marked. The bottom two pictures depict the sagittal view and the coronal view. All of these are essential when we're making sure that we have precise segmental localization of disease process. There are several different types of CT scans. The standard that we talked about, a high-resolution CT scan, which makes much finer cuts so that disease process is much better visualized. A low-dose CT scan, which reduces the radiation dose that is being used for lung cancer screening. And then the famous CT angiogram, where we inject contrast timed so that it passes through the different vessels that opacify with the contrast, and we have better visualization of occlusion of those vessels, mostly used in cases of pulmonary embolism. High-resolution CT scans are used for evaluating patients with suspected interstitial lung disease. The optimal utilization of HRCT requires the understanding of the secondary pulmonary lobule, which we will talk about. This is the lung's basic structural unit. Several components are normally visible on thin section HRCTs. Let's talk about the structure of a lung lobule. The lung lobule is the structural unit of the lung. It consists of an interlobular septal region, the centrilobular region, and the lobular parenchymal region. The interlobular septal region includes the interlobular septa, the subpleural septa, pulmonary veins, and the lymphatics. The centrilobular region has the pulmonary arterial and lymphatic branches, also includes the bronchiolar branches. And the lobular parenchymal region contains the alveoli itself and their pulmonary capillaries, as well as interlobular septal fibers. Based on CT scan, we have 4 different radiographic patterns that we discuss. The first one is the reticular pattern, also depicting fibrosis. The second one is an alveolar pattern, which is also sometimes described as ground glass or consolidation. The third, as you can see, is a nodular pattern where you can see multiple small dot-like structures. And the fourth is a mosaic or cystic pattern where you can see large cavities of darker areas interspersed with regular or normal lung areas. Let's put all of this acquired knowledge into clinical picture. Let's talk about recognizing some common abnormal radiographic patterns. Let's go back to our case. It's a 46-year-old female who comes to our office with complaints of 2 days of shortness of breath and cough. She has had some hemoptysis but is unable to quantify it. She's a smoker and her blood pressure and temperature are normal. Her heart rate and respiratory rate are as above. Let's talk about some differential diagnosis on this patient. So one of the things that we need to talk about first is something called a silhouette sign. In cases of a normal chest x-ray, whenever there's a air-water interface, you will see a sharp demarcation or delineation of that region. The silhouette sign is the loss of normal air-water radiographic density and that interface, shown here with the white arrows that are downward pointing. The silhouette sign is not limited to this area. However, the silhouette sign can be anywhere wherever there is loss of those sharp boundaries or demarcation boundaries where the air-water interface is no longer present. If we think about our case, our lady could easily have had a pneumothorax. She is a smoker and she's young. She has been coughing for a few days now. Pneumothorax is defined as air around the lung in the pleural space. It is seen as a unilateral, darker, homogeneous shadow outside of the zone of vascular lung markings, as we'll show you in a second. Causes of pneumothorax, they could be spontaneous, such as rupture of a visceral pleural bleb, or more commonly after invasive procedures, such as thoracentesis or central lines that are generally done in a healthcare facility. These procedures can puncture the visceral pleura and cause leak of air into the pleural space. In this X-ray, if you can notice on the right side where the white arrows are, you see a sharp, straight boundary going along the right side of the lung. There are vascular markings before this, but no vascular markings are seen after this sharp boundary. This area where no sharp markings are seen is the area of the pneumothorax. On the left side, you can also see an area where there are no lung markings. However, this is not a straight line or a sharp line. These are more consistent with bullae or large blebs, which are rounded, shown here by the red arrows, also at the periphery of the lung. On a CT scan, a pneumothorax is much easier to visualize. As you can see here, the darker areas in both these pictures depict the pneumothorax. Air has filled these areas and collapsed the lung by putting pressure on the lung tissue. Prompt recognition of a pneumothorax is critical, especially in patients on mechanical ventilation and in settings of trauma. Tension pneumothorax is a life-threatening complication of mechanical ventilation. It leads to a dramatic reduction in venous filling because of pressure that the lung and air are putting on the heart, leading to reduced perfusion and eventually cardiovascular collapse. The treatment of tension pneumothorax is needle decompression. This is followed by a chest tube or a tube thoracostomy because you cannot leave a needle in somebody's chest. Going back to our case, one of the other differentials in this case was air outside the chest cavity, or air under the diaphragm, also called as subdiaphragmatic gas or pneumoperitoneum. In these pictures, you can see on the top the chest X-ray, both on the right side and the left side depicted by the red and blue arrows. You can see air under those diaphragmatic regions. This is air under the diaphragm. In terms of a CT scan, it is again much easier to see. The white and black arrows are depicting air under the diaphragm. This is a surgical emergency and needs surgical intervention. Here is another picture of subdiaphragmatic gas or air under the diaphragm on the right side depicted with the white arrows. The diaphragm is shown with the blue triangle. There are several other external and internal objects that are seen on this X-ray, and it is by far not normal by any means. Let's now talk about how to develop a basic interpretive strategy. So one of the things that I recommend is to start thinking about X-ray interpretation in these terms. First question you ask is the chest X-ray normal versus abnormal? Usually if you're looking at a chest X-ray, it should be abnormal, because we do chest X-rays not on normal people, but people who are sick. So we're looking for something. The second question to ask is, if you see an abnormality, is it natural versus unnatural? Unnatural abnormality would be something that would be inside the body, versus an unnatural would be something like a bullet or a chain from the outside. There is no reason to think that you cannot have natural and unnatural abnormalities both in the same X-ray at the same time. You can. The third question to ask is, if there is an abnormality, is it inside the chest cavity versus outside the chest cavity? This leads to a good descriptive process to explain the abnormality. But this is not everything that we do in terms of interpretation. We also have to talk about the normal things, or compare the abnormal things with the normal things that we see. I like to use this chest X-ray to discuss the interpretive strategy that I just talked about. The first question is this a normal or abnormal chest X-ray? Most people would agree that this is abnormal. The second question is the abnormality natural versus unnatural? In this case, there are several different things that are visible. They are both natural and unnatural abnormalities. The natural ones would be air under the diaphragm. It happened within the patient's body, but there's also lines and tubes that are seen here, which are unnatural and could be both inside and outside the chest cavity. Using this interpretive strategy, again, gives us a good idea of what the abnormalities are. You will still have to think about the ribs, the bones that you see, the heart borders and shadows, the diaphragm, and those other normal structures that may not always be abnormal or affected by a disease process. When interpreting chest X-rays, a few points need to be considered. Develop a systematic approach in terms of where you're going to go from, either from outside to inside, top to bottom, inside to outside. Use that approach repeatedly so as not to miss abnormalities and normal structures. Identify normal anatomy, because that is important to know before you can say something is abnormal. Conduct an orderly search for defects. Remember my scheme of, is this normal versus abnormal, natural versus unnatural, and internal versus external. Use common landmarks, and then plan additional diagnostic or therapeutic procedures based on the interpretation of your